The following podcast is part of a certified educational activity titled Test Your Knowledge, Optimizing Prophylactic Management of Hemophilia with Novel and Emerging Non-Factor Therapies. Access the entire activity and complete the post-test at peerview.com/TNQ860. Downloadable slides and practice aids are also available.
Hello, this is Victor Jimenez Yuste from La Paz University Hospital in Madrid, along with my colleague Guy Jan from the Children's Hospital in Los Angeles. In a series of educational modules, we are going to explore recent developments with non-factor therapy in hemophilia, but also offer you the opportunity to learn based on your own preference and interest. So let's hear more about the unique format.
Find out how much you know about optimal management of hemophilia through a simple 3-step process in this self-assessment activity comprising 5 question modules. First, answer the baseline question to evaluate your knowledge and skills. Next, review the supporting evidence with Doctors Victor Jimenez Yuste and Guy Young, and then answer the question again to demonstrate what you've learned. Each correct answer automatically counts towards post-test completion, which means that getting your CME credit is fast and easy.
You have just answered a question about unmet need hemophilia care, so let's look at some supporting evidence. Nowadays, we have a very good treatment for hemophilia compared to the last decade, but we still have some unmet needs in hemophilia A and B. Probably the first is to control breakthrough bleedings and joint deterioration. I think it's important because the goal that we have to meet in the future is try to achieve zero bleed in our patient. Of course, the main part is in joint bleed, but also we have to look for control subclinical bleed that could lead to some kind of joint deterioration. Nowadays, we have an important amount of burden in the treatment of hemophilia. So another of the goals in the future is try to have an easier and less frequent administration of the treatment for patients with hemophilia. In the last decades, the most important complication related to the treatment is the development of inhibitor. So in the future, we have to have available treatment for patients with and without inhibitors. Is another important issue. WFH has encouraged us to try to find a quality of life similar to the rest of the population for our patients with hemophilia. So probably in the future, we have to provide to our patients that they have a more active life similar to the rest of the population and have a social and social integration. Quality of life is another important issue because WFH has encouraged us that our patients achieve a similar quality of life to the rest of the population. So I think it's an important issue. We have to work in the future with the new therapies. And finally, of course, the most important issue is that we have an access to the treatment for all patients with hemophilia. So what is the treatment, or what are the advances we have now in our patients? For people with hemophilia A and B, nowadays we are working and we are offering our patients prophylaxis and also treatment for on-demand and surgery. We started the history with plasmatic product, and in the last year we have a standard half-life for factor VIII and factor IX. For patients with inhibitors, again, hemophilia A and B, we have APCC and recombinant 7A. And in the recent year, we have now a new drug, mimetics, that is a factor VIII mimetic that indicated the prophylaxis, but only in patients with hemophilia with and without inhibitor. So we have new therapies in the portfolio that are going to arrive in our daily treatment. And most of these therapies that are called not factor therapy share key similarities that may improve the management of our patient with hemophilia. The first we have to remind is that they are indicated in prophylaxis. It means that they are not monotherapy. So in case we have our patient require surgery or have a breakthrough bleeding, we need to add treatment in this patient in case of patient with inhibitor by patient agent, in patient without inhibitor, probably a factor substitutive therapy with factor. Also, is the new treatment are effective for both patients with hemophilia A and B. Also, a very important condition that they can be used in patients with and without inhibitor. So probably these two conditions may increase the number of patients that could be treated with this new non-substitutive therapy. Nowadays, with the administered factor, we have peak at troughs because this is the PK of the concentrate that we are using. And this kind of drug usually maintain a steady state, so they are not peak at troughs in the future with these drugs. Most of them, as you know, have a dramatic change because they have subcutaneous administration compared with intravenous that we have nowadays. And also the administration is with a very low frequency, reduced frequency compared with administration nowadays with therapy, intravenous therapy we are using. So in this table is summarized the current and emerging non-factor therapies. The first to arrive was emicizumab. It was the first generation of factor A mimetic. An indication is patient with hemophilia A with without inhibitor, and it was approved in the first indication in patient with inhibitor and last in patient with without inhibitor. The second mimetic drug is Mimet. It's a second generation of factor A mimetic. It's indicated in patients with hemophilia A, and now it's integrated in phase 3. The next drug is an anti-TFPI that we are going to discuss later. It's concizumab. It's indicated in patients with hemophilia A and B, and now they are in phase 3, but recently has been approved in Canada for patients with inhibitors against hemophilia B. Marstacimab is another anti-TFPI indicated also for hemophilia A and B, and now they are in the phase 3. And fitusiran, that we are going to discuss in the next module, is a RNA drug that is interference in the production of thrombin, and are indicated in hemophilia A and B, and also in phase 3. And finally, there are a different Serpin. We are going to discuss about Serpin protein C, that is a serine protease inhibitor indicated in hemophilia A and B, and now in the phase 1 and 2A. So this is more or less the drugs that are coming. So I want to ask to my colleague Guy Yam, what is your opinion about the recent approval in Canada for concizumab, and what their thoughts about this interesting point?
Yeah, thank you, Victor. Yes, it's nice to see that concizumab was approved in one country. As we know, once a drug is approved in one country, especially a country like Canada, where they do take safety very seriously. The fact that it was approved in Canada gives me confidence that it will be approved in the United States as well, in Europe and throughout the world. So to me, it just signals that one health authority, a health authority that we can trust, does truly believe that the drug is safe and effective. All right, well, now we're going to explore some of the mechanisms that underlie factor mimetics in hemophilia. So this is a figure that takes a look at the function of factor VIII in comparison to a factor VIII mimetic. In the top figure, you can see factor VIIIa with all its domains working on a phospholipid membrane. Typically, that would be platelets. And factor VIIIa's job is to bring factor IXa and factor X into the proper alignment, as you can see to the right of the main figure. What the factor VIII mimetics do is basically exactly what it says. They are mimicking the function of activated factor VIII. These are bispecific monoclonal antibodies where each arm of the antibody will bind to one of the substrates. So in the figure below, you can see a figure of an antibody. One arm grabs factor IXa, the other variable arm grabs factor X. And as you move to the right, you can see that it brings factor IXa and factor X into the proper configuration to allow for the formation of factor Xa. So that's at its simplest how these factor VIII mimetic drugs work. Now, there's been a lot of information already published on emicizumab. Emicizumab has been licensed throughout the world and has become a very commonly used drug for factor VIII prophylaxis or for prophylaxis in hemophilia A. This slide really kind of summarizes the pivotal trials, which were all called the Haven trials. This summarizes Haven 1 through 4, and this was a publication that kind of took all the trials together and looked at long-term efficacy. And basically on the bottom, what you see is the annualized bleeding rate as we march from the early part, so weeks 1 through 24, and you could see the treatment interval weeks going to week 25 to 48 and so on, moving to the right. And essentially you see that the annualized bleeding rate is a bit higher at the beginning, but then it goes down and remains low and below 1 throughout the treatment period, going out beyond 2 years and beyond even close to 3 years. The figure on the right is percent of patients with 0 bleeds, again, looking at those intervals, and you can see that it starts out at about 71% and ends up at like 82% as patients have stayed on emicizumab. So overall, most patients on emicizumab are not bleeding, and even those that have bleeds, the number of bleeds is low. Moving forward, we also have the Haven 7 trial. So the Haven 7 trial is taking a look at using emicizumab in infants. For the most part, infants were not part of the Haven 1 through 4 trials. And so what is the Haven 7 trial? It's a multi-center, open-label study of emicizumab in infants, basically meaning children less than 12 months of age, with severe hemophilia A without factor VIII inhibitors. The treatment regimen is going to be basically the same treatment regimen that all other patients get. They'll have 3 loading doses of 3 milligrams per kilogram every week. And then the patients will be put on 3 milligrams per kilogram every 2 weeks for a year. So yes, they will be required to be on the every 2-week regimen for 1 year. In the extension phase beyond that, patients can choose to switch to a weekly regimen or an every 4-week regimen if they would like to do that. The main endpoints are the number of treated bleeds, including all bleeds, treated spontaneous bleeds, treated joint bleeds. But there are many other endpoints that are going to be looked at, including inhibitor formation, including markers of bone health. And so we're going to have a lot of data on this long-term 7-year trial. And you'll see that data coming out slowly over the next 7 to 10 years. Just briefly, what have we seen so far in the interim analysis of Haven 7 with respect to bleeding? In the panel on the left is the model-based ABR, annualized bleeding rate, across different bleed categories. If you look at treated bleeds, you see that the rate is 0.4. It's pretty much the same as we saw in the pediatric trial Haven 2. All bleeds, which would include small things like hematomas that don't require treatment, was 1.9. There were no treated spontaneous bleeds. There were no treated muscle bleeds. The panel on the right looks at the percentage of patients with 0 bleeds across these categories. 77.8% of the patients had no treated bleeds, and nearly 43% had no bleeds at all. Of course, 100% had no treated spontaneous bleeds because, of course, I mentioned already that the ABR there was 0. So all the treated bleeds in Haven 7 were related to some sort of trauma. Moving on, though, emicizumab is not the only factor VIII mimetic that is in development. Or I should say, of course, emicizumab is already licensed, but additional next generation, if you will, factor VIII mimetics are in development. The one that is furthest along is called Mimate. And this is outlining to you the Frontier 1 study. So the Mimate trials are called Frontier. The emicizumab trials, as you remember, were called Haven, so we'll refer to them as the Frontier studies. This is the phase 1 multiple ascending dose, that's what the MAD stands for, where patients on the first cohort started with a lower dose, and then the doses were increased as we went from cohort 1 to 2, 2 to 3, and so on. And you could see the dosing on the bottom. I don't think for this presentation it's really important to remember all of this dosing. I mean, ultimately, in the phase 2, phase 3 trials, the dosing will be defined, just as we have defined dosing with emicizumab. Well, let's take a look a little bit at the efficacy in this phase 1 trial. Now, again, phase 1 trials are really not designed to look at efficacy. They're really for dosing and safety, but we can glean some information out of it. If you look at the panels, this is the number of bleeds on the y-axis. If you look at cohort 1, you see in the blue bars traumatic bleeds, in the green bars spontaneous bleeds. So in cohort 1, which is the lowest dose cohort, we are seeing a number of bleeding events in the different patients. But once we get to cohort 2, the next highest dose, and moving along to cohorts 3, 4, and 5, as the dose increases, you see very few bleeds at all. There was one patient in cohort 5 that was a bit of an outlier that had quite a lot of spontaneous bleeds. But if you look overall across those boxes, cohorts 2, 3, 4, and 5, you don't see too many blue bars. In fact, most of the patients are not having any bleeds at all. And mimate appears to have a safe and well-tolerated profile. The bottom line is that there were some patients who had injection site reactions. These were mild. The number's around 10%. It's a bit lower than what we saw with emicizumab. There was one patient who withdrew due to hypersensitivity reactions, but otherwise the number of adverse events was, generally speaking, quite low. As you can see quickly in the numbers in the grid, I'm not going to read every one of those numbers, but overall the percentage of adverse events was low, and those related to mimate were really quite low. So moving forward is the phase 3 frontier development program. There's going to be a number of trials here. The first one is Frontier 3. There will also be an extension study, Frontier 4, and there'll be additional studies beyond that. Essentially, the main approach for Frontier 3 is that there'll be a run-in period where patients who are not currently on prophylaxis, that could include Heme patients with and without inhibitors, those patients will then be randomized to either continue with no prophylaxis or to continue mimate prophylaxis weekly or mimate prophylaxis monthly. After a period of time, those patients will then continue, if they wish, on an extension trial. Those who are randomized to no prophylaxis, of course, will be offered to go on mimate, and those who are already on mimate will continue on mimate. Another group will come into the trial already on prophylaxis. Again, this could be Heme with or without inhibitors. Of course, those patients who already are on prophylaxis will not be randomized, and therefore they will go straight onto mimate, either with a weekly dose or a monthly dose. And so essentially that's the main phase 3 trial that is going to be looking at enrollment. You can see another trial on the bottom, which will include pediatric patients, and that is designed in a fairly similar fashion.
So what about non-factor therapy with TFPI antibodies? So let's start to discuss on action and learn more. So anti-TFPI antibodies are under development for the management of patients with hemophilia inhibitor. The first of this class is concizumab. Concizumab is assessed in the EXPLORER-7 trial, focused mainly in inhibitors, and as we mentioned before, it's now currently approved in Canada under the regulatory review in the United States and also in Europe. So the trigger of coagulation nowadays, the exposure of tisular factor, this first reaction of exposure of tisular factor allow to join with factor 7A, and this complex is able to activate factor 10, and after several reactions to generate a high amount of thrombin and the end lead to the blood clot. So I think one of the most important inhibitors of the coagulation in this phase is TFPI, the inhibitor of tisular factor pathway, and this can regulate the activation of coagulation. So concizumab is antibody designed to join to TFPA. He's joined to one of the domain for administration in the subcutaneous prophylaxis across all these different subtypes of hemophilia, and works independently from factor 8 and factor 9, and increase the initiation phase of the coagulation through this increase of the levels of 10A. This mechanism allow to create enough amount of thrombin to generate and prevent bleeds. So the clinical development program, as mentioned, is called EXPLORER-7. EXPLORER-7 is the clinical development to explore how this molecule acts in patients with inhibitor. The design here in the slide is a patient who came from the MAM. The main important part is the comparison between arm 1 and arm 2. This group of patients came from on-demand treatment, and the patient continued with no prophylaxis, and the comparison is against concizumab on prophylaxis. So this is the main part, because M3 and arm 4 are prophylaxis with concizumab, and at the end of the trial, the patient used concizumab as a prophylaxis treatment. So during the development of this molecule, we observed some thrombotic event, not fatal thrombotic event. So this leads to modification in the mitigation measure to treat breakthrough bleeding, and also to use different doses that I'm going to explain later. So following the restart of the trial, after observe all these complications, and also to design this new measure, we have not observed any kind of thrombotic event following this new recommendation. So in ASH 2022, the result of in Explorer 7, the use of concizumab inhibitor patient, we could observe that the overall median ABR was 0, both in hemophilia A with inhibitor and hemophilia B with inhibitors, and also across all the different subgroups of treatment, spontaneous treatment, or traumatic, or treatment of traumatic joint bleeding, the median ABR was 0. And there was an update in 2023 in the EHAT meeting, when the median ABR for arms 1 to 4 concizumab was 0.8 for treat spontaneous and traumatic bleeding episode, and the median was 0 for both treating and spontaneous traumatic joint bleed and target joint in arm 1 to 3. So this is a very interesting program of concizumab. To conclude from the result for exploring several concizumab prophylaxis, we can say that the overall median ABR of concizumab prophylaxis was 0. That was effective in reducing ABR compared with patients with no prophylaxis with hemophilia A and B and inhibitor. That the estimated mean ABR was around 1.7 for concizumab prophylaxis and 11.8 for patients with no prophylaxis. That appear to have a safe and well-tolerated profile in both hemophilia A and B with inhibitor. That there was not thromboembolic events were reported after restart of the treatment. In the prior treatment pause, there was only one event of non-fatal renal infarct in this trial. And the concizumab exposure was stable over the time, and free TFPI was suppressed and thrombin generation potential normalized. And when we analyze the quality of life, there is a real positive trend observed in the different domains of concizumab.
So let's take a look at some other non-factor therapies with different mechanisms of action. One, a small interfering RNA, and one, a serine protease inhibitor. Let's start with fitusiran. Fitusiran is a small interfering RNA that basically suppresses the production of antithrombin. Now, you might ask, why would we want to do that? Well, hemophilia is a disease where thrombin generation is impacted. So patients basically cannot generate a sufficient amount of thrombin. Antithrombin is the inhibitor of thrombin. So another approach to improve thrombin generation in patients with hemophilia is not to necessarily do something to improve thrombin generation, but to reduce the elimination of the thrombin that is generated, or the inhibition of the thrombin that is generated. So essentially, what fitusiran does by knocking antithrombin down is allows the small amount of thrombin that patients with hemophilia can generate to work in a feedback loop to generate more and more thrombin. So fitusiran has been studied and continues to be studied in multiple phase 3 trials. We call them the ATLAS trials. So we have the ATLAS-INH trial, which is for patients with hemophilia A or B with inhibitors. The ATLAS-AB trial is for hemophilia A or B patients without inhibitors, which includes an on-demand arm. The ATLAS-Pediatric study, of course, is a pediatric study. And the ATLAS-PPX trial is a trial in patients with hemophilia A or B with or without inhibitors who have previously been on prophylaxis. That's what makes ATLAS-PPX different from ATLAS-AB. And then ultimately, all the patients in these trials can enroll in a long-term extension trial called the ATLAS-OLE, or long-term extension trial. So let's take a look at some results from the trial. So first of all, does fitusiran do what we want it to do? And the answer is yes. You can see the figure on the left is the mean percentage change in antithrombin level. And the antithrombin level goes down significantly, 80 to 90%. Does that result in improved thrombin generation? So the panel just to the right shows the thrombin generation. And you can see that in the blue, which is the patients who receive fitusiran, thrombin generation does go up. So the bottom line is, does fitusiran reduce antithrombin as intended? It does. Does it increase thrombin generation as intended? It does. And then, does that result in reduced bleeding? Because ultimately, that's the goal, as we heard from the initial slide on unmet needs. And so you can see here from the ATLAS-PPX trial that the patients who were previously on factor or bypassing agent prophylaxis had a median observed ABR of 4.4, and while they were on fitusiran, the median was 0. The percentage of patients who had 0 treated bleeds on factor or bypassing agent prophylaxis was 16.9%, and that increased to 63% in the patients on fitusiran. So this slide sort of encompasses everything that fitusiran is about. Looking into a little bit more detail, here's results from the ATLAS-INH trial. Remember, these are patients with inhibitors. The left panel is the patients who were using bypassing agents on demand. They had a median ABR of 16.8, a mean of 18.1. On fitusiran, the median was 0, and the mean was 1.7. So fitusiran clearly was very effective in patients with inhibitors at reducing bleeding in comparison to previous on-demand treatment. Here's the fitusiran ATLAS-AB trial. And again, this included an on-demand arm. These are patients without inhibitors, and they could have hemophilia A or B. And similarly, you see in the on-demand arm an ABR of 21.8. With fitusiran, the median is 0. In the right panel, you see the percent of patients with 0 treated bleeds, which is 5% for those on demand and 50.6% for those on fitusiran. If we expand it to those less than or equal to 3 treated bleeds, it's 15% for the on-demand clotting factor concentrates and goes up to 84% or almost 84% for fitusiran. And then here we're looking at the results of the ATLAS-PPX trial, where we have patients previously on bypassing agent prophylaxis, either hemophilia A or B with inhibitors. Their ABR is 6.5. On fitusiran, the median ABR is 0. In the right panel is patients hemophilia A or B without inhibitors. Their median ABR on factor prophylaxis is 4.4, and on fitusiran was 0. So moving on to the Serpin molecule. So this is a molecule that's intended to inhibit activated protein C, or APC. So you see the mechanism on the right. First, to understand that we have a circulating pool of protein C. Protein C requires activation by thrombin. That activation results in activated protein C, and activated protein C then goes back to inhibiting thrombin by inhibiting both factor 5A and factor 8A. The idea here, though, is that only the activated pool of protein C is being inhibited. The regular pool of protein C is not being touched. And the thought behind this is that could this result in improved hemostasis without increasing the risk for thrombosis? And that's still to be determined. Here you can see that Serpin PC has been well tolerated. You can as well see the annualized bleeding rates that go down significantly from in the 30s down to 6 in part 3, down to 2 in part 4. There's several different parts here that involve different groups of patients. Suffice it to say that if you take a look at Serpin PC overall, the median ABR in this group of patients, who is particularly challenging because they've had a lot of previous bleeds. These are patients who've never had prophylaxis in their lives. Having their ABR down to 2.2 is really quite interesting. There were no observed treatment-related adverse events. And then interestingly, there were no increases or important increases in the D dimer. So that does suggest that perhaps this molecule will not increase the risk for thrombosis the same as the other ones. Now, again, that has to be tested in a much broader trial and in a phase 3 trial. Victor, do you have any thoughts or comments about Serpin PC?
I think that I only want to stress one of your comments, that we have to try to find the correct balance between hemostasis and thrombosis. So probably we need more data, as you mentioned, in the phase 3 trial. So I think I'm convinced that in the future we have more insight about this new molecule. I think it's a very interesting approach, but probably we need more data in the future.
Thank you.
So I think the next step is how to prepare, how to introduce in the clinical use of these new non-factor therapies. So in the next part, Dr. Jan and I will provide some concise sample how to spec the become available drug in the market. I will start saying that some of the new therapies, as we discussed in the first part, will require less frequent administration, that most of them are drugs that we are going to use subcutaneously, but there are some difference, mainly in the frequency and the route of administration of this drug. All of them will administer subcutaneous, but in the drug that are in development, azithromycin will administer one monthly to once every other month. In the case of anti-TFPI, will vary from one daily to one weekly, and in the anti-APC, the administration will be one monthly. So at the end, all these molecules will offer less burdensome prophylaxis with compared with the treatment that we have nowadays, and probably they are going to increase adherence. Probably all this factor will increment the quality of life of our patients. Talking about how can patients and healthcare professionals prepare for the drug, for both for adolescent, children, and adulthood, fitusiran and concizumab have a potential role for emerging non-factor fitusiran and concizumab in children, adults, and individuals. And also, we have some concern related to these drugs. As we mentioned, there have been some kind of thrombotic complication that lead to change the treatment that we use for treatment through bleeding, and also they have changed in the different dosing regime of these factors. So I want to discuss with you first how to use how to deliver the concizumab based on the result of the different trials, that there was different patients with different levels of concizumab in plasma. This is the design for the molecule in the ongoing clinical trial, and also in the future. The molecule will start with 1 milligram per kilogram body loading dose, and the next day is following with the dose of 0.2 milligram per kilogram body weight. And after 4 weeks of administration of daily 0.2, there will be a PK determination, and based on the plasma levels, they are going to modify the dose. If the patient is lower than 200 nanogram per milliliter, we are going to increase the dose to 0.25, and the patient is in the higher part, above 4,000 nanogram per milliliter, we are going to decrease the dose to 0.15. If the patient is between these two values, they are going to maintain the same dosage that we started. So I think it's important, this consideration, and also that the patient prior to initiation of concizumab have to stop the prophylactic treatment, because I mentioned there is 1 day of loading dose, and then we achieve very fast the steady state. This treatment should be initiated in the non-bleeding state, and of course, due in some lean and younger patients, we have to avoid to administer the drug intramuscular. So we have to inject it, try to find a place when you can administer the drug in a subcutaneous way. So in the next part, Dr. Jan is going to explain some consideration about fitusiran administration. So Guy, when you want, you can start it.
Yeah, so similar to concizumab, fitusiran is going to also have some therapeutic drug monitoring and dose adjustments, and that also came out of the clinical trials. And what was found in the clinical trials is that patients who had thrombotic events ended up mostly having antithrombin levels of 10% or lower, whereas patients at higher antithrombin levels still had good bleed protection, however, did not have thrombotic events. And so as a result, it was determined that we want to keep the lower threshold of antithrombin at around 15%, which offers a little bit of a buffer above 10% to try to mitigate this risk of thrombosis. In fact, to try to even eliminate the risk for thrombosis if that's possible. It was also noted that patients at higher levels of antithrombin, certainly above 35%, we saw that there was a reduced efficacy. In other words, we started to see bleeds. And so as a result of all of this simulation work, looking at the pharmacokinetics, pharmacodynamics, understanding the risks of thrombosis at low levels, the risks of bleeding at high levels, it was determined that patients on fitusiran should maintain an antithrombin level between 15 and 35%. So how are we going to do that? Well, basically all the patients in the trials, even those who had been on different doses, were assigned to receive a dose of 50 milligrams every 2 months. If that turns out to be the dosing regimen for most patients, that's going to be pretty fantastic when you think about the fact that you'd only need 6 subcutaneous injections per year. But essentially, that will be the start. Then patients will have antithrombin levels measured. If there's any level below 15%, meaning the risk for thrombosis is probably higher, the dose will be reduced to 20 milligrams every 2 months. If those patients continue to demonstrate low antithrombin levels, in other words, they're extremely sensitive somehow to fitusiran, they actually would then be discontinued. For the patients on 50 milligrams every other month, if it turns out that their antithrombin level is too high, in other words, more than 35%, their dose will come back to once a month. It'll be the same dose, 50 milligrams, but only once, but then once a month instead of every 2 months. If still the antithrombin level is too high, they will then go back to the dose of 80 milligrams once a month, which was actually the original dose in the phase 3 trials. And just to complete things, for those who had a dose reduction to 20 milligrams every 2 months, if their antithrombin level is then too high, they could end up on a dose of 20 milligrams every month. So in other words, patients could end up on doses as low as 20 milligrams and as high as 80 milligrams, but either 20, 50, or 80. It's not any number in between. And they may end up on a monthly dose or an every other monthly dose. It is estimated that 80% of the patients will be able to be treated with the 50 milligrams every 2 month dose, and that there won't be a need for too many dose adjustments. The other important thing to realize is that once patients achieve an antithrombin level that is stable based on these early dose adjustments, it is believed that these patients will not require further dose adjustments. In other words, when you start somebody on fitusiran, you may have to make a dose adjustment or two just to find what is the appropriate dose for that patient. But once you get a stable antithrombin level between 15 and 35%, the feeling is that that will continue to remain stable and that we won't have to continue to be checking antithrombin levels and making dose adjustments constantly. And so with that, I think we can conclude by saying that there are potentially a lot of benefits that are going to come with these non-factor therapies. Primarily, as Victor said, these are going to be all administered subcutaneously. So instantly, there's an advantage there. You can see many of them are going to be administered at relatively infrequent intervals, once a month, every 2 months, once a week. But even for those that are administered daily, there may be some advantages to a daily administration. That could include the fact that the washout of that medication will be quicker. And for patients who are having some sort of side effects or somebody who might need surgery, or somebody who's at more risk for thrombosis, we might want something that has a daily infusion with a rapid washout. The other thing is that most of these molecules or most of these drugs are going to come with very simple devices to use. So I think overall, so we're looking at these drugs, we're going to substantially reduce the treatment burden. It looks like we will also improve the efficacy. And then we will have to monitor for the risks for thrombosis, as we've seen some of these drugs have led to some of that. And so we'll need to have some good strategies for monitoring the patients. Victor, any final thoughts?
I fully agree with your summarize of this thought. I think that in the future we have to select the right population for the different drugs. I think that we have been discussing that with the new drugs we are not able to individualize, but seeing how we are going to dose concizumab, and also the presentation you have give about how to monitor antithrombin, I think we are able to monitor in the future and also to individualize the treatment of our patients. So I think that you have done a very good summary of this new drug. I think it's the future is very hopefully about the to cover the unmet need that we have with more of our patients still.
I'd like to thank all of you for joining us, joining me and Professor Jimenez Yuste from Madrid for this learning module. We hope it was informative for you, and we hope to see you again soon at another of these events or in-person meeting as well. Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/TNQ860. This activity is supported by an educational grant from Novo Nordisk Incorporated. Remember to download the slides and practice aids.